Good morning, good afternoon. On behalf of VHealthcare, I would like to welcome you to this scientific symposium. My name is Elias Mariolis and I am the dolutegravir medical lead in Europe. In the next 40 minutes, you will have the opportunity to watch two pre-recorded presentations by expert virologists. Professor Carlo Perno from Italy will focus on barrier resistance of drugs and antiretroviral combinations, and then Professor Anne Marcelin from France will approach methods of diagnosis and focus on specific resistance mutations. During the presentations, please submit your questions to the speakers via the question panel, as there will be live discussion with the two virologists at the last 15 minutes of the symposium. I hope you will enjoy the meeting and you will find this useful. Thank you very much. I'm handing over to Professor Perno.
Good morning, everyone, and welcome to this symposium sponsored by VIV. My role is to bring you through the concept of barrier to resistance, remembering that we are in a virological context in which everyone is a big expert on virology. So I'll try to discuss the issue from our point of view, that is your point of view, that in order to detail what's going on in this field that is moving very quickly. Resistance was always an issue since 1987 when we started to work on a therapy with HIV. Think about AZT. It is still an issue today. However, it has changed in terms of amount of importance and rule of development resistance. So let's discuss together what happened in the last 30 years in order to understand where we are going and how to use at best our drugs, which are the limitations, which are the strengths that we consider in our clinical practice. First of all, drug resistance is not a virological phenomenon per se. If we look at it from the clinical and sociological point of view, we see that the development resistance encounters many fields and many factors. When we talk about poor adherence as one of the causes of resistance, saying, yes, it became resistant because it's poorly adherent, so it is irrelevant. No, it is not irrelevant. The lack of adherence is today particularly the major cause of resistance. So we need to consider a number of factors when we talk about resistance that encompass both virological and clinical point of view. So resistance is the end of a phenomenon that needs to be taken into account very carefully in order to avoid that it appears and to treat at best in the future the same patient. If the patient is fully non-adherent, even if we change therapy, the results will be very poor anyway. So many factors need to be taken into account. And in addition, we have to remember that with minor exceptions, with today's drugs, the presence of resistance occurs essentially when the drugs are below therapeutic concentrations. This might happen for lack of adherence. This might happen for a drug-drug interaction, so for many other factors. While in the past, this was not true. Even the best drugs that we had 20 years ago could develop resistance, even if used properly with a perfect adherence. So the field is changed, and we need to consider it. We also have to remember that always drug resistance has been associated with a virological outcome and with a clinical outcome. These articles have been published recently, have been presented recently, so they tell us that still today, the issue of resistance and its association with the virological outcome is relevant. So we need to remember it. Keeping in mind that resistance might appear not in few weeks as it happened in the past, but will appear perhaps years after the beginning of a wrong therapy. But it will appear. So we need to consider it for the long-term therapy. We should not forget that with minor exceptions, we do not cure anyone. And unfortunately, the Berlin patient passed away just a few days ago for leukemia. And but a cure remains a dream that we need to carefully follow, but not yet achieved. So treatment will be for life. We cannot afford to let the patient have failure with resistance. What happens in a case of using the new drugs regarding resistance? Let me take the advantage of being in a VIV symposium and taking the liberty of using dolutegravir as the tool to demonstrate what's going on today. This might be true for the other new modern drugs, but certainly being in a VIV symposium, let me just discuss with having dolutegravir in mind. What we see is that in Viking, dolutegravir demonstrated to be a great drug. Nevertheless, if dolutegravir was used in patients that already had developed resistance to integrase inhibitors, thanks to the use of first-class integrase inhibitors, we still have a rate of resistance that relatively high in those patients that failed dolutegravir. But in terms of barrier to resistance, we need to consider the issue from many different standpoints. So we discussed before that resistance is a function of many parameters, but also the genetic barrier to resistance is a function with at least 3 key parameters. One is the effect of mutations on the drug susceptibility per se. The second, the impact of mutation on viral fitness. And the third is the number of mutations, their weight, and their relevance in practice. What does it mean? It means that the concept that we're used to use, that is the very simple concept, the resistance is the number of mutations that the virus is required to develop to escape from a certain drug, is true up to a certain point. There are other factors that need to be taken into account. And this is an example, again, taking dolutegravir in mind. That may be true also for other drugs in the same family, even though the data that we have today are mostly with the dolutegravir. This is a classical example, very common for all of us, of development of resistance. In the case of dolutegravir, however, the development of resistance is light for dolutegravir if at the beginning the virus didn't carry any major mutations. We said that in Viking that was not true. Some clone with the resistance, some quasi-species with resistance was already present. But if no resistance is present since the beginning, this is a typical evolution of a patient that fails. We do have evolution of the virus, but it doesn't go to the red. That means it doesn't reach full resistance, essentially because of what is described by the arrow below. The arrow below describes something that is somewhat hidden in clinical practice and in virological practice that we needed to take into account. That is, when mutations that let the virus escape from the pressure of the drugs do not let the virus become highly fit, at the end, these mutations are unable to develop properly. So we reach a sort of equilibrium in which we have some resistance, marginal, you see yellow, not red dots, with a fitness that remains lower than the wild type. This explains why the new generation of integrase inhibitors, the second generation, normally fail without major mutations. You see in this graph that reports a very arbitrary positioning of the drugs that we have and we had in the past in reference to their potency and their genetic barrier. You see that the new drugs, let's call dolutegravir and darunavir 600 BID, what is reported there is 600 BID, are better than what we had in the past. That is the reason if we use darunavir 600 BID in naive patients, in the majority of cases, we would have lack of resistance at failure. That is the same for dolutegravir, and is somewhat the same also for bictegravir, for the information that we have so far. And this is driven also by the other factor. We described the 3 different factors that play a role in the barrier of resistance. That is something related to the pharmacokinetic of the drug, in particular with the capacity of the drug to bind irreversibly the target, that is the integrase. You see that the dissociation T half-time ratio shows for dolutegravir a prolonged binding compared with the other first generation integrase inhibitors, and shows also that this remains higher also in case of presence of other mutations. In general, you might lose some time, as it is, for example, for 92Q compared to wild type. In other cases, you don't lose anything. That is the case of 138K. Still, the dissociation time remains higher than the other drugs. So the ability of dolutegravir to remain attached to the target, substantially attached, even under condition of resistance, let us understand why this drug has an edge compared to the first generation integrase inhibitors. Similar data come from the saline study. In general, the dolutegravir produces less resistance compared to raltegravir, even in patients that were already treatment experienced. So they already had problems. With the previous failures with resistance. Even in this case, dolutegravir that has a higher genetic barrier seems to be working better than raltegravir. And the number of mutations that are present is minimal, though not zero, but minimal, if mutations are already there. So further, we understand how it's important that we deal with our patients since the beginning out of, at best, by positioning the best drug since the beginning up front, in order to let them use their capacity of controlling the virus in the best condition. And you see here that both dolutegravir and bictegravir have a very good resistant profile, even though, as you can see, orange versus green and blue versus yellow in the case of dolutegravir and bictegravir, it is not the same. It is similar, but it's not the same. But certainly, the rate of resistance developing against these two drugs is far lower than what found for the first generation of integrase inhibitors. In addition, if we use the classical triple therapy with the dolutegravir, so we return to the original point, the rate of resistance is really minimal, if not completely zero, at least in our clinical practice and the studies that are available. The same occurs for bictegravir trials. In bictegravir registrative trials, both bictegravir and dolutegravir at failure obtained results in very good in terms of the complete lack of resistance, both in the integrase as well as the nucleoside reverse transcriptase. So that means that the protection given by these two drugs is substantial. And resistance to dolutegravir is also very rare, also in all the treatment experienced patients that the other study is doing. So we return to the same point as we said before. Once the drug are used properly, in the proper condition, the rate of resistance is function of the capacity of the drug to have a high genetic barrier. Dolutegravir is the blockbuster in this way. And indeed, we can really say that what we showed with dolutegravir in registered trial is something that we found also in real-world data that can be true also for other drugs of the same class if the genetic barrier is maintained very high. You see that this study that I'm sure will be further discussed by Anne Marcelin that will follow my presentation. You see that the INSTI resistance associated with the dolutegravir failure in the first line is very, very low or zero. So we can say that originally, the efficacy of the drug is very high. Only in conditions, look at the third groups of columns, in which dolutegravir used in experienced patients that already failed other integrase inhibitors, we start to see some resistance. So this provides us a clear evidence that the potency that has been shown and the genetic barrier that has been shown by dolutegravir in registrative trial is reported also in clinical practice. Same is for dolutegravir-based regimens in viral suppression, limited or no resistance at all. So in other words, the data are very consistent in saying that when you have a drug very potent with a high genetic barrier, with a high, very good PK, and easy to be administered, the probability of developing resistance remains very low. And this explains why the rules has changed so well recently. Even though even the best drugs might fail with resistance if used improperly. This is the case of dolutegravir monotherapy. Dolutegravir monotherapy is no longer something that we can suggest and should not be used in clinical practice, because even a very good drug like dolutegravir misses potency and loses the ability of not generating resistance, as it is this case. Similar in case of, there are other conditions in which there are strange mutations that appear, like the T797A. This is a mutation that theoretically should not appear in these patients, in patients treated with dolutegravir. However, as you see in the left panel, if you already have very heavy mutations like 140, 148, the only appearance of 97A produces resistance and virological failure. So just to conclude this part, the picture is very complex. We cannot just say resistance, no resistance, genetic barrier high, genetic barrier low. We need to evaluate so many factors in order to treat our patients at best, considering that when we deal with very high genetic barrier drugs and very potent, like dolutegravir, we are safer than in the past. However, things may go wrong in case we use them improperly. An example, this example is true also for bictegravir. I said that bictegravir develops a very marginal resistance or no resistance in registrative trials. However, in a single treatment-naive patient, there was a development of the classical heavy mutation 263K in plus 184V in the reverse transcriptase in case of failure. So you see that something happens. It happened for bictegravir, and we will see that it happened also for Gemini, for the dual therapy that we are going to discuss in the last part of my presentation. We know that Gemini study showed no resistance up to week 46. At week 144, a single patient developed a resistance to dolutegravir, dual therapy, very similar to the resistance that we see here with the bictegravir triple therapy. They are single cases. They do not show that the drugs are losing efficacy, but they tell us that something goes wrong in clinical practice that we cannot define at best at the beginning of our work, because so many conditions play a role in the failure and the development of resistance. We said about PK, we said about lack of adherence, we said about drug-drug interaction, etc., etc., etc. So many factors need to be taken into account. This doesn't tell us that the drugs are not good. This tells us that we need to consider many factors when we decide what to do. So to go toward the conclusion, we can say that indeed there are virological elements that play a role in the development of resistance. We have pharmacological elements, and we have also target elements that need to be taken into account in the definition of the resistance. Is it true also today? Yes, it is, to the point that today we can dare to think about two drugs. Why? Are we changing the dogmas? No, we are just changing the drugs. So just to restart from what we said before in terms of potency and genetic barrier, with the new drugs, we can dare to do something that was not effective in the past. This is an article, New England article in 1998, in which patients that achieved a success with the zidovudine, indivunavir, lamivudine have been split after success in groups treated only with indivunavir, with the zidovudine and lamivudine. And you see that in few weeks, not months, not years, you have a loss of efficacy with the heavy resistance. Why? Because the drugs that we had in the past, look at the right panel, were not good enough. We couldn't afford to use two drugs at that time. Today, however, by using the new drugs, you see that the rate of the decay is so similar for two drugs and three drugs, look at the right panel, that we can really dare to think, and not only to think, to consider treating our patients with the 2 drugs, not because, again, the dogmas have changed, but because we know that the problem is not the 3 drugs, but the problem is having at least 3 mutations required by the virus to escape from the antiviral pressure. If you have a drug with a very high genetic barrier and potent, like it is dolutegravir, and perhaps other drugs, perhaps very good boosted PIs, we can afford thinking about 2 drug regimens, even though dolutegravir is the only one that has been approved up to this point. Is it true? Why? Well, for many, many reasons. One of them is the great potency of integrase inhibitors that act at a stage, a very delicate stage of viral replication, in which there are very few pre-integration complex present. So stoichiometrically speaking, even marginal amount of drugs is sufficient to block the virus. This explains well the potency of integrase inhibitors, in particular the 2nd generation integrase inhibitors, to the point that dolutegravir can be considered a major co-agent to build a 2 drug regimens. I would not suggest 2 drug regimens with any drug. I would say that in order to go for 2 drug regimens, we need to have at least 1 drug that has peculiar characteristics. Characteristics that let us say, as it is this summary of clinical trials, that with the 2 drug regimens, including dolutegravir, we can afford achieving results that are similar to those achieved with the 3 drugs. Essentially, because the kinetic decay of the virus is very sharp, independent of the number of drugs that are used. Also, for patients with more than 100,000 copies, remembering that the roof, there is a top viral load for this study that was 500,000 copies. So between 100,000 copies and 500,000 copies, the rate of decay is similar for 2 and 3 drugs. So what can we conclude with this very brief summary that is designed essentially to let us think at best how time is changing, as Bob Dylan has said many years ago for in other conditions and in other environment. Time is changing. Time is changing. We need to think new. The new drugs let us think new. And the genetic barrier in virology needs to be thought new. Is a concept that is far more complex than a classical idea of the number of mutations excuse me, required to the development of resistance. The number of mutations is the pillar of the concept, but not the only factor. So many other factors play a role. New drugs that have peculiar characteristics that were not present in the past let us think new, because they decrease to a minimum the rate of resistance at the time of failure. Remembering, however, that resistance remains one of the key elements to be taken into account in the frame of the modern therapeutic approach, essentially designed to keep the virus under control for decades and not only for months, and being at the same time less toxic and easy to be managed in real life. If we decrease too much the potency, we take a risk. We can afford using the new drugs in a peculiar condition, as it is with only 2 drugs, only if a number of elements are fulfilled. Which are these elements? Essentially, the potency of the drug, the genetic barrier, the simplicity of its use. In other words, all elements that are found in very few drugs, and dolutegravir is one of them, that let us go beyond the dogma, not disrupting the dogma, but beyond it, just to say that there are conditions in which we can treat patients with the 2 drugs safely if the right conditions are fulfilled. We need to take into account the attention that we have to deal with our patients, and consider everything that comes in the literature. But the evidence today brings us to a new era of treatment. I wish to thank you very much for your attention on this important topic, and I leave the floor, the virtual floor, to an excellent researcher, Anne-Geneviève Marcellin, professor in Paris, that has a great experience in the field of virology. She published so much in this field, that will talk about another issue that is very important, that is the 184V mutation. That is a mutation that needs to be taken into account in our clinical practice. Anne, the floor is yours.
Hello, my name is Anne-Geneviève Marcelin. I am professor of virology at the Pitié-Salpêtrière Hospital in Paris, France. And I am very happy to be here today with you to speak about the impact of the 184V mutation. There are several ways to perform genotypic resistance testing. First, for patients with detectable viral load, and then for patients with low and undetectable viral load. So we can perform Sanger sequencing on RNA for patients with detectable viral load. This is currently the gold standard to perform genotypic resistant testing. It has been shown its clinical utility in randomized clinical trials. And this kind of test detects viruses in at least present in at least 20% of the virus population. So for patients with a low and undetectable viral load, we can perform Sanger sequencing on DNA. This test has shown its clinical utility in retrospective studies. However, it detects fewer resistance mutations than pooled data from historical RNA genotyping. And more recently, there are some techniques using next generation sequencing that have been developed. In RNA, some studies have shown its clinical utility in retrospective studies, mainly in treatment naive who started treatment with first generation NNRTIs. This test can detect viruses in between 1 and 20% of the virus populations. However, currently there is no recommendation of the cutoff to use. Probably it's between 5 and 10%. And lastly, for NGS in DNA, there are very few studies that have been evaluated this kind of test. These studies are mainly descriptive, and there are very few data on its clinical utility. So now if we speak about the 184V, what it is and what it does. 184V and 184I are NRTI mutations that can be selected by 3TC and FTC. And it has been shown that these mutations reduce the susceptibility to 3TC and FTC. They cause low-level resistance in addition to abacavir and DDI, and they increase the susceptibility to to TDF, zidovudine, and D40, and they slow the emergence of resistance to some NRTIs. So 184V and 184I are associated with a reduced viral replication in vivo and in vitro. They reduce the RT processivity, they reduce the nucleotide dependent primer unblocking, and they increase the RT fidelity, which reduces spontaneous mutation. 184I usually emerges first and is outcompeted by 184V due to the superior RT function and higher replication rates. And 184V is quickly repressed by wild-type virus after discontinuation of the drugs that maintain it. So we know that 184V has an impact on the virus fitness. Indeed, it has been nicely shown in this study published in 2006, showing that in patients with virus harboring 184V, 3TC monotherapy may have less impact on the immunological and clinical outcome than complete therapy interruption. Indeed, you can see that the probability of immunological and clinical failure in patients receiving lamivudine monotherapy here was lower than in patients in complete therapy interruption. In addition, the patients under 3TC monotherapy had a lower viral load and higher CD4 cell count. In this study, they showed also that there was a fitness recovery in complete treatment interruption arm and not in the 3TC monotherapy arm. So how frequently is this mutation detected? The prevalence of transmitted 184V in treatment-naive patients is very low, generally reported as being below 1%. However, this mutation is more prevalent in patients following treatment failure. And in this study, you can see that the 184V can be present in between 35 to 80% regarding the different region, and also regarding the different regimen associated, especially with NNRTI. The disease prevalence of 184V in case of virological failure can be high. However, in Western Europe, in this study, 184V was present in approximately 30% of cases. So once 184V has been selected, what happened in patients with a long virological suppression after? So in this study, we studied the dynamics of drug-resistant associated mutations in DNA in reverse transcriptase to investigate the clearance of the mutations over time. And we showed that among the resistance and mutations analysis, some mutations were no longer detected after 5 years in approximately 72% of patients. And you have here the example of these patients. He had a 184V in the past in the RNA at time of virological failure. And then we measure the prevalence of the 184V mutations in the DNA over time after subsequent virological suppression. And you can see here that the mutation was present in 35% of the viral population here, and there was a decrease thereafter until 0% 5 years later. So this results show that there is a clearance of archived drug-resistant mutations, and for example, for 184V in cell-associated HIV DNA after a long period of virological control. And this is reflecting probably the residual replication in some reservoir of the fetus viruses and leading to the persistent evolution of the archived DNA resistance profile. So now, if we look at what is the impact of this archived 184V mutation. So first, I will speak about the impact of this mutation, these archived mutations in the patients switched with a triple regimen. And in this study, these Gilead studies conducted in patients, in virological suppressed patients, the efficacy of bictegravir, FTC, and TAF was studied in patients switched from boosted PI plus 2 NRTIs or dolutegravir plus abacavir 3TC. And these patients had either historical genotype in the past, or proviral DNA resistant genotyping was performed at baseline. So 78% of these patients included in these studies had at least one genotype available for the resistance analysis. and they evaluate the virological outcome after 2 years of bictegravir FTC TAF and the impact of the previously selected resistance mutations. As you can see, among the genotype available, 16% of patients had at least one NRTI resistance mutations, and 10% had a 184V in their historical or prevalent DNA resistance test. 21% had the NNRTI resistance mutations, and 8% to resistance mutation to PI, and 1.9% to resistance integrase inhibitors. So if we look at the virological outcome by baseline resistance mutations, among the pool data, the virological efficacy was at 98%, and there was no effect of the presence of resistance mutations, either primary resistance mutations, other primary resistance, or archived 184V. So long-term bictegravir FTC TAF efficacy was not affected by the pre-existing primary protease RT or integrase resistance on baseline, and no effect of the archive 184V mutation. To summarize, the prevalent DNA genotyping detected previously undocumented 184V in 10% in these studies. The pre-existing 184V mutation was associated with older age, a longer time since ART initiations, a longer time on prior regimen, and current suppression on a regimen of boosted PI plus 2 NRTIs. 184V was frequently detected with other primary resistance mutations, but was the only resistance detected in 27% of cases. And finally, bictegravir FTC TAF maintained a high rate of virological suppression of participants with archived 184V mutation. So if we look now at the impact of the 184V mutation of the efficacy of dolutegravir plus abacavir and the 3TC regimen prescribed in treatment-experienced patients. This study was an observational longitudinal study prospective in 5 European HIV cohorts. And all these patients were switched to an abacavir 3TC dolutegravir regimen. And all the patients had at least one resistance mutations profile available before the introduction of abacavir 3TC DTG regimen. The primary virological outcome was the virological failure, defined as 2 consecutive HIV RNA measurements above 50 copies, or 1 measure of viral load above 50 copies together with a change of ART. And virological blips were defined as a single HIV RNA above 50 copies, followed by return to virological suppressions below 50 copies. So this is the estimated probability of remaining free of virological failure and or blips by the presence of 184VI mutations. This is a composite outcome. And when combining these both outcomes, the effect on 184V reaches statistical significance. However, the effect of 184V was weak and does not reach statistical significance in the multivariate analysis. There were some limitations in this study. First, there was a very low rate of virological failure at 1.3%, and 42% of patients with a 184V had also at least 2 times in their genotype. So in this study, the authors conclude that in ART-experienced patients, switching to dolutegravir abacavir 3TC, there were very few virological failures, and there was no evidence for an impact of previously acquired 184V mutations on this outcome during the study. So in France, in my team, we performed also a retrospective study to evaluate the impact of previously selected 184V mutations in virological suppressed patients switching to dolutegravir abacavir 3TC. And the interest of this study was that these patients had only the 184V on their genotype with no other NRTI resistance mutation associated. And among the 155 patients who were switched to a dolutegravir abacavir 3TC regimen, you can see that they were previously treated by a boosted PI with either tenofovir plus FTC or abacavir 3TC. And during the follow-up, there was no virological failure after the switch. Only 3 blips were observed at month 3 after the switch. So we conclude that archive 184V mutations does not affect the response of these virologically suppressed patients who switched to dolutegravir abacavir 3TC for at least 6 months of follow-up. And this was right, this was true even when using an ultra-sensitive viral load assay copy. So we have seen the impact of 184V on the triple drug regimen switch, and there were some studies about the potential impact of these mutations on dual therapies. So this is a cohort study made in Italy, and they retrospectively study the virological efficacy of 2 drug regimen in 436 subjects with and without 184V in their last available genotype. Most of these patients were treated by boosted PI in combination with 3TC, and 30% were treated by dolutegravir plus 3TC. The results have shown that there was no impact of the 184V after the switch, either in presence of 184V or not, and with no difference between patients treated by boosted PI or dolutegravir. So the previous 184V did not seem to have a significant impact on the virological efficacy with this regimen after a switch. It is important to note that probably the time of the duration of virological suppression is an important point to take into account before the switch, because in this additional analysis, selecting patients with less than 3 years of virological suppression, the probabilities of remaining free of virological failure were 67% in the 184V plus group and 96% in the 184V negative group. So the duration of the virological suppression before the switch in case of ARCAV resistance mutation could be an important factor to take into account. Now that there is a very recent publication of a clinical trial, a pilot study conducted in Spain that had evaluated the impact of historical 184V or I on a switch to dolutegravir plus 3TC. So these patients had no 184V at baseline in the proviral DNA after Sanger sequencing. However, they could have or not an historical 184V in their past historical genotype. And then they were switched to dolutegravir plus 3TC. So you can see that in this pilot trial, dolutegravir plus 3TC was effective at 96 weeks in maintaining long-term virological control despite the history of 3TC resistance, and because there was no virological failure in the arm. And they perform a more detailed analysis by NGS to look for the presence of archived 184V mutations in the DNA. And they did not see any impact of the presence of these archived 3TC resistance mutations. And to finish, in the Tango study, this is a switch study of virological suppressed patients to dolutegravir 3TC versus continuing TAF containing regimen. And in this resistance analysis, we can see that there were no only 4 patients with proviral 184V at baseline in DNA in the dolutegravir 3TC arm and 3 in the TAF-based regimen, and there were no virological failure. So in this post-hoc analysis of stored baseline samples, all assessed participants in the dolutegravir 3TC group with proviral 184V at baseline maintain a viral load below 50 copy at week 48. So to conclude this presentation, 184V is a major NRTI mutation that results in high-level resistance to 3TC. However, this mutation is particular because we have shown that this mutation has an impact on the virological fitness. And generally, antiretroviral regimens are not recommended for use in patients with known or suspected resistance to components of the regimen. However, bictegravir, TAF, FTC, dolutegravir, abacavir, and 3TC, or dolutegravir plus 3TC. For this regimen, there are some available clinical trial and real-world data that indicates that bictegravir and dolutegravir in combination with 1 or 2 NRTIs or optimized background regimen were suppressed even in the presence of 184V at baseline. So these results showed that we have to improve our resistance testing to detect resistance mutations, even at undetectable VRMA. And this can allow the clinicians to optimize their therapy in the case of switch for treatment simplifications. So we need further investigations through, for example, ultra-sensitive technology to clarify the clinical impact of resistant presence in PBMCs. So this is an example of the benefits of joint efforts among virologists, immunologists, and clinicians in order to properly position these virological parameters into clinical practice and current guidelines. So thank you for your attention, and now we will have a session of questions. So I will be happy to keep your question and to answer to them with Professor Pernaut.
Good afternoon and welcome to this live section of our scientific symposium. My name is Elias Mariolis, and I'm the dolutegravir medical lead for Europe in VIV Healthcare. And it's my great pleasure to be here live with Professor Marcelin from France and Professor Perno from Italy, in order to answer some of the questions you have submitted during the presentations. Of course, you have the opportunity to submit more questions in the next minutes. We will have approximately 10 minutes to discuss before the end of this symposium. So we'll very quickly start with the first question, and I would like to ask Professor Perno. So Professor Perno, the first question is around this case of this single case of resistance we saw in the Gemini trial, in the data that were reported in the 144 weeks. So the question is, do you think, in your opinion, that this challenges the barrier to resistance of this combination? Thank you.
The answer is half virological and half clinical. I think that one case of resistance amongst hundreds of patients cannot change my mind. Something that happens is always a bell that rings, that always needs to be considered in our clinical practice. Also, if something unexpected occurs, this is not an evidence that what we said is wrong. It is an evidence that is always important to consider new information that comes from the field. So if one patient has a resistance over about 1,000, doesn't change my mind. It is an expected result, because we know that in those patients in which the adherence is not optimal, and or with the conditions of high viral load and or low CD4 and etc., something unexpected may happen. So I would say that we have a case, we keep it in mind, we have a lot of attention on that. It doesn't change my mind.
Thank you very much, Professor. Professor Marcelin, any comment from you?
Yes, with pleasure. I think that the important thing is to, because this particular case of this patient, he has a detectable viral load at week 132 and until 144, if I am right. And I think that we should avoid this continuous replication of the virus under whatever treatment. So I think it's only one case, but yes, we have to keep in mind that with dolutegravir or other drugs, we do not have to let the patients with virus replication under treatment.
So you mean we need to reinforce the adherence of the patients?
Of course.
Thank you. All right, thank you very much. Professor Marcelin, you presented at your first slide many useful data around the different techniques you used, like the proviral DNA and the NGS. There is one question about the clinical use of intact proviral DNA assay. What is your opinion about this?
For example, in my center, we use genotypic resistance in DNA for patients, for those we want to perform a switch. Because sometimes, you know, of course, if you have the post-historical genotype in RNA, it's better, it's more informative. But if you don't have this post-RNA genotype, DNA genotype can be helpful before performing the switch, because if there is a mutation, you know that the mutation can be there. So you can choose a different treatment if you have a mutation. Of course, if there is no mutation, this is a good signal, but it's not like a, you know, like a passport to perform the switch. But I think it's important. if you have a mutation, but if there is no mutation, you have to know that the test could be less sensitive than the past historical RNA genotype. But in clinical practice, yes, we do use this kind of test.
Thank you very much. And there's another question around the proviral DNA, and I can start with Professor Masellan and then I'll also ask Professor Perno. The question is, if you want to switch a patient to a treatment, a virologically suppressed patient, but you don't know the past history, or if you know that there was a history of virologic failures at some point in the past without resistant mutations, would you select to do proviral DNA, or you will change the patient without performing proviral DNA?
No, I will change based on the genotypic DNA.
Okay, so you would.
I don't know what.
My
yes, please
perception, if I can say something on that, Elias, I think that this question paves the road to a different perception that comes from different cultures. Personally, I think that what Anna said is totally right. So whenever you have the chance to do a test that let you know something more, in order to reduce the risk of failure of our patients by knowing that we have to treat them for life, why should not use it first? At the same time, whenever the test is not available, or there is no clear-cut evidence that the test can be useful, there is no reason to implement it. So in other words, what I hate in our field is that everything needs to be positioned at the lowest possible level, because some has no chance to use the most sophisticated systems available. So those laboratories and clinics that have availability of sophisticated tests, in my opinion, they should use it. Those that do not have it available may not use it because they don't have. That doesn't mean that, so in other words, they have to change without the resistance test in DNA, period. But if you have it, there are no reasons not to use it. So the differentiation is on the basis of the availability of the laboratory test.
But you know, it's very easy to perform. It's like RNA genotype. There is no particular technical problem to perform this kind of test.
Yeah, but as a matter of fact, Anna, if you don't trust it, you don't do it.
Yeah, of course.
I do trust, and I do. You trust and you do. Those that don't trust don't do. So I don't know what to say. I do use it, period, as you do.
Okay, I think we have 2 more minutes before we'll close this live session. So there is a question around the patients with high viral load and the use of dolutegravir and lamivudine, and we know that the label does not exclude these patients, but in the guidelines this is a prerequisite, a requirement. Professor Perno, what is your opinion for the use of dolutegravir and lamivudine in patients with high viral load?
Elias, when there is a substantial evidence that things should go in certain direction. At the same time, I tend not to put our patients at risk. So we have a substantial evidence that a combination in those patients that fall within the categories covered by Gemini and Tango. For those patients that have a higher viral load, I'd rather be conservative and tend to keep it conservative until there will be evidence that we can play a game in different conditions. But again, we return to the point that we said before. This combination provided absolutely good coverage in terms of viral load and in terms of resistance. There is only one patient with resistance. I don't want to take any risk for our patients. So I would definitely go for dual for all the patients in which is allowed. I tend to be conservative and use the 3 in those conditions in which we do not have evidence.
Thank you very much, Professor. So I think we are close to the end of our symposium. Thank you very much, Professor Perniel, Professor Massellan, for participating, for making those recordings. I think they were very useful. And for the attendees, thank you very much for your questions. We're not able to address them all, but please fill the evaluation form. There will be some questions for you that will pop up. Thank you very much for your participation. Good afternoon.